Hi everyone, welcome back. This is our first module after our exam, so hopefully you guys have been doing well and all of your study techniques are working for you. This week we are covering pancreas and adrenal gland. We're going to be starting off with pancreas, so hopefully you're listening to this lecture first. Both of these PowerPoints are pretty short. There's not a ton of information that goes with both of these lectures, but the information that we do have is very important for us. The pancreas is one of those organs that's really difficult for ultrasound to evaluate fully, and we know that because of where it's positioned and how much bowel gas kind of surrounds the different portions of this organ. So finding pathology in the pancreas is very challenging for us, and a lot of these pathologies, as we go through this PowerPoint, they all kind of look very similar to each other. So whenever we see anything near the pancreas, on the pancreas, associated with the pancreas, we really want to be doing a further evaluation with CT or MRI. And we're going to kind of touch upon that at the end of this PowerPoint. So one of the things that you may happen to see as you're scanning the pancreas are going to be acquired cysts. So these are just like regular cysts. They behave like regular cysts. We know we're not concerned about simple cysts, but when we're looking at the pancreas, a simple cyst can be a sign of something else going on, or a simple cyst could actually be a different type of finding. So anytime we see a cyst on the pancreas or near the pancreas, we need to be evaluating that further. We never just ignore it. When we're looking at the kidney or we're looking at the liver and we see a simple cyst, we kind of don't really do any follow-up on that patient because we know that those are going to be benign. They're pretty straightforward, clear-cut findings. But on the pancreas, we really want to make sure that we're not missing something bigger or more important by just calling it an acquired cyst. So chances are we're going to be following up on these type of findings. So if it is in fact an acquired cyst, it's going to arise from within the gland itself, so coming from that functional tissue. It's going to contain that epithelial lining from the pancreas. Clinically, the patient is not going to have any symptoms associated with this, but as you can see in that bottom picture, these cysts can get kind of big. And if we do have a cyst located at the pancreatic head, we know that there are a lot of other structures in that region, right? So we have that traveling towards our porta hepatis or common bile duct. All of those structures kind of sit in that region, and if we have a really large cyst sitting there, it can compress those adjacent structures, giving us some other types of symptoms as well. So on ultrasound, it's going to be nice and anechoic, well-defined, clear-cut borders. It's usually going to be unilocular, meaning it doesn't have any septations or any pockets within it, but sometimes we can see those loculations inside of it. Again, we are following up on these acquired cysts of the pancreas. We're not just ignoring these or letting the patient continue on with their normal day-to-day life, doing a little bit more investigation. Next, we're going to talk about cystic fibrosis, and you're probably wondering, why are we talking about a lung condition with the pancreas? And actually, the two are very closely related to each other. So cystic fibrosis, this is going to be a multi-system type of condition and disease, and it's actually a congenital disease, so this is something that you just happen to have, and it affects the lungs and the digestive system itself. So what happens is our endocrine glands, we know our pancreas is an endocrine gland, it's going to produce way too much mucus in the body, right? So we have this excessive amount of this really thick mucus, and when we have all this excess mucus in the body, it's going to start to obstruct and block our normal pathways. So our digestive system is going to be blocked with this thick mucus. Our lung, right? So all of those bronchial pathways are going to be affected by this thick mucus, and that's why people who have cystic fibrosis, they have that mucus in their lungs and all the pathways in their lungs, and they can't fully breathe, right? Their lungs can't fully function because of that blockage. These blockages are also going to result in the degeneration of the normal tissue, right? Because as we know, if our tissue doesn't function normally, it can't do that forever, right? So that tissue starts to kind of slow down and stop working, and that tissue starts to die off because it can't function the way it wants to. And as it's starting to die off and stop working, it's going to become replaced, so that space where the normal tissue was is going to become replaced with these small cysts. So these little cysts, these little pockets of serous fluid, these little pockets of mucus are going to accumulate that space where that normal functional tissue used to be. So now our organs are really not going to be working the way that they should be. So this is it's a pretty common type of disease. So about 30,000 people a year in the United States are diagnosed with this. That's quite a bit. And about 75% of these diagnoses are going to be in children under 2. So this is a really, really unfortunate diagnosis, and this is a lifelong condition. We have yet to find a cure for this. We try to treat cystic fibrosis on a case-by-case basis, but unfortunately these patients have a shorter than average lifespan, and they're really only living till they're about 40 years old. So very unfortunate, not a diagnosis that anyone wants to hear for themselves or for their children. Now, we commonly, as we said, associate cystic fibrosis with the lungs, right? But the pancreas is actually going to be the most commonly involved organ in the abdomen. Okay, so the lungs are going to be the most affected by cystic fibrosis, but then we also have our pancreas. So when we have all of this thick excess mucus, all of those pathways in the pancreas are going to become blocked. We know we have our duct of Wirsing, right? We have all of those ducts that really carry out a lot of important functions. So when we have that blockage of those pathways, it's going to lead to acute pancreatitis. As we know, well, we don't know quite yet, but with acute pancreatitis, when we are constantly responding to that inflamed state, it's going to be undergoing fatty replacement because that tissue is not going to be working properly. So this is going to be the most common manifestation in the pancreas. This is going to be the most common manifestation that occurs in the pancreas. So when you have cystic fibrosis, you have that thick mucus that's blocking those pathways. That blockage is resulting in acute pancreatitis. Now our pancreas is inflamed and it's kind of working in overdrive. So again, that degeneration of the tissue is going to be occurring. And with that degeneration, we are going to have replacement of that tissue with those fatty cells. And that's going to be the most common thing that we are evaluating our pancreas for in patients that we know have cystic fibrosis. So of course, pulmonary complications are going to be the most common type of manifestation of cystic fibrosis, but we don't want to be surprised if we see a patient coming in for an abdominal ultrasound and on their indication it says history of cystic fibrosis. So we want to make that connection on our end. Now on ultrasound, as we already know, the pancreas is super hard for us to be evaluating, but now when we have cystic fibrosis, it's going to take on these different types of variations. So we're going to see a very echogenic pancreas, and that is because we have that fatty cell replacement, right? So now we have more fatty cells in the pancreas than we normally would, so it's going to appear brighter, more echogenic, more hyperechoic. We're also going to see pancreatic calcifications in some patients who have cystic fibrosis. Again, that's going to depend on how long they have been dealing with this and how much the pancreas is going to be affected by it. We also can see those cystic replacements as well. So we're going to see pancreatic cysts that are usually going to be small in size, so less than 3 millimeters in measurement of diameter. We are going to see, or we can see the pancreatic ducts becoming very narrow. We normally aren't seeing the pancreatic ducts anyway, but sometimes with these really echogenic pancreases, or with these pancreases that have these little cysts or calcifications, it can kind of draw our eye to the pancreatic ducts a little bit more. So we'll be able to see that narrowing of that ductal lumen. And then sometimes we can also see a well-defined fluid-filled serous mass. So again, we don't want to just be assuming that something is an acquired cyst or a simple cyst, because it can be associated with something more than that. So if we look at these different variations, we have our echogenic pancreas here, so all of that fatty tissue replacement. We look at our picture to the right, this is all of that cystic replacement, and the pancreas is still looking echogenic as well. And then here on the bottom, we have our serous-filled fluid mass right here. And here we have just a chest x-ray showing what normal lungs should look like versus what cystic fibrotic lungs look like. So air on x-ray appears black, the radiation travels right through the lungs very easily, and it just appears black, kind of like how fluid does on an ultrasound. So picture on the left-hand side, this is going to be a normal healthy chest x-ray. We have all clear lung spaces here, right? Nice healthy lung. This is going to be the heart right here. We see our ribs throughout that chest. We see a little bit of, kind of like whiteness right here, kind of looks like spider webs. Those are all the normal vessels and bronchial pathways of normal healthy lungs. Now, if we look at the picture on the right side, you guys can kind of see, oof, those lungs do not look as black as the lungs on the left side do. So that means that there's something going on in those lung spaces. There's something blocking those lung spaces, and that's going to be all of that excess mucus that cystic fibrosis produces. Next, we have acute pancreatitis. So this is something that we oftentimes will see orders for, but we can't, unfortunately help the patient as much as CT would be able to. So acute pancreatitis is the sudden onset of pancreatic inflammation. It's going to be mainly caused by what we know as the 5 Bs, and this is booze, blood, bile, bug, and birth. I don't make up these acronyms, but this is something that the registry likes to test you on. Kind of like the 4 Fs for cholelithiasis. So booze, alcoholism, this is going to be the most common cause of acute pancreatitis. Blood is going to be any type of recent surgical intervention, or if you were in a car accident or blunt force trauma to the epigastric region. Bile is going to be any type of biliary disease. So that will be the most common cause in a biliary sense. So if you have Morizi's syndrome or Caroli's disease, those are going to be the most common biliary causes. Alcoholism is going to be the most common cause overall, but biliary disease is going to be more common than just cholelithiasis in a biliary sense. So of course, if we have a gallstone, that can also cause acute pancreatitis as well, but a little less likely than if you have a different physiologic biliary disease. Bug is going to be any type of infectious process. So you have any type of viral condition, any type of parasite, any type of bacterial disease. It's not just like a bug bite that causes it. When we're talking about bug, we're talking about like, oh, when you have a cold, you have a bug, right? Stomach, you have, a stomach bug, any type of infectious viral or bacterial process. And then birth, you can have just a predisposition to acute pancreatitis in a congenital sense. So a lot of young teenage patients will have these episodes of this sudden onset of that pancreatic inflammation, and it's for really no other reason than, unfortunately, that's just how their body is responding. We also have additional risk factors that can cause acute pancreatitis, but they're a little less common than the 5 Bs. Cystic fibrosis, as we know, can cause acute pancreatitis, pancreatic cancer, duodenal reflux, if you know anyone who has acid reflux or GERD, metabolic disorder. So if you have a difficult time processing some type of carbohydrate, protein, fat, anything like that. And then drug exposure. This can be any type of chemo drug, radiation drug, recreational drugs. These are all going to affect your pancreas in some way or another. Clinically, these patients are going to have severe pain. It's going to be epigastric pain, but it's going to be constant, and it can be radiating towards their back. They're going to have fever, sweating, nausea, vomiting. They are going to have a really distended, gaseous-filled abdomen. They can have an ileus or a blockage of their gastrointestinal tract. They also can go into ARDS, which is acute respiratory distress syndrome. So if you have acute pancreatitis, it can actually start to affect your pulmonary system, so how you're breathing, and we really don't want that. We want to make sure that the cardiac system and the respiratory system and the pulmonary system are all working properly, but acute pancreatitis can have an effect on that. We want to be aware of our laboratory values. So this is really going to be the telltale sign of if a patient has acute pancreatitis or not. They're not really relying on ultrasound for this diagnosis. We're really going off of blood work. And then if we are relying on imaging, it's more so going to be in the CT or MRI category. So we are going to see elevated lab values. That means our white blood cell count is going to be elevated. Our bilirubin is going to be elevated. Serum lipase, serum and urine amylase, all of those proteins are going to be, or rather enzymes are going to be elevated with acute pancreatitis. Now we can have some complications from acute pancreatitis, meaning if we don't get this under control right away, it can result in an abscess, hemorrhage, acute peritonitis, right? So our whole peritoneal cavity is inflamed. We really don't want that. That can lead to, bowel rupture, perforation, sepsis. It really can go down a really bad rabbit hole. We also can have biliary and duodenal obstruction, fluid collections, edema, thrombosis of the portal and splenic veins. We also can have a phlegmon, which we'll learn about, and a pseudocyst, which we will also learn about. So let's take a look at what this is going to look like on ultrasound. So again, we are not the modality of choice. CT is. If we are evaluating this on ultrasound, we are going to see diffuse enlargement with loss of the normal echo texture. So it is going to start to become a little bit more isoechoic to the liver, a little bit larger than it would be. We're going to see poor visualization of that splenic vein traveling through that pancreas. We are also going to see dilation or compression of the pancreatic duct as well. Dilation is probably going to be the more likely finding rather than compression. Now, if we look at both of these pictures, the picture on top is probably a little bit more common if we are to evaluate the pancreas during acute pancreatitis. But the picture on the bottom, you can kind of see how that head is a little bit more prominent, right? Right here, looks a little bit more focal, and we could very easily confuse that with some type of discrete or isoechoic pancreatic head mass. So again, we're really relying off of the symptoms, we're relying on that blood work, we're relying on CT. So we really don't want to just assume that something going on in the pancreas is one thing when it really could be something else as well. So next we have Phlegmonous Pancreatitis. So we kind of just mentioned the phlegmon, but what the heck is Phlegmonous Pancreatitis? It sounds like a caveman, type of name. So this is actually going to be a very severe complication of acute pancreatitis. And what happens is the pancreas tissue is so inflamed that it actually starts to kind of come out of the pancreas, and it forms this like solid mass outside of the pancreas, and it's non-infected. Okay, so this tissue, so it's kind of like a splenule, right? An accessory spleen, where we see this like accumulation of splenic tissue outside of the spleen, but right next to it. So that's kind of what this is, but it's a non-infected mass of inflamed tissue. So the tissue is inflamed, but there's no infection in this tissue. So if there's an infection that's causing the acute pancreatitis, this phlegmon is not going to be affected, but it will still be inflamed. Okay? Kind of a very bizarre concept. Clinically, we're still going to have symptoms of acute pancreatitis, and we can also have a palpable epigastric mass depending on where this phlegmon is located. On ultrasound, it's going to appear solid, hypoechoic, because it's still pancreatic tissue. We can see this very easily on CT, but on ultrasound, we can very easily miss it or mistake it for something else going on. Next, we have hemorrhagic pancreatitis. So again, like phlegmonous pancreatitis, this is a complication of acute pancreatitis. This is when we have bleeding within the pancreas or surrounding the pancreas. So basically the pancreas and all of that inflamed tissue is kind of just like under attack, right? So it's bleeding and has nowhere to go. So that blood is going to start to accumulate either in the pancreas or around the pancreas, depending on where that bleeding is occurring. Clinically, we're still going to have symptoms of acute pancreatitis. We're still going to have severe abdominal pain, nausea, vomiting, distension, ileus. Our laboratory values are still going to be elevated in terms of those enzymes, but now we are going to also be seeing decreased hematocrit, and that's going to be the main indication of if there is a bleed going on in cases of acute pancreatitis. So if we see any levels changing with pancreatitis and those levels are blood markers, that we know is going to be some type of bleed going on. There's a hemorrhage going on in response to that pancreatitis. On ultrasound, we are going to be able to visualize that blood, so we're going to be able to see that fluid accumulating. New blood is going to be anechoic in this sense, and as it starts to age, or if it's been there for a while, it continues to progress, it's going to become more echogenic. So here we have our fluid collection. This would be a rather new hemorrhage. It's looking a little bit more anechoic than it is echogenic. So we just want to be aware of not only what's going on with the pancreas, we want to be aware of what's going on around the pancreas as well. Now, we've talked about acute pancreatitis, but there are some patients who have these chronic, repeat, recurrent episodes of pancreatitis. And this is really unfortunate. These people have very poor quality of life because of this. So when we have these persistent episodes of pancreatitis, of course, it's going to lead to organ damage, right? So we're going to really see these three types of manifestations of chronic pancreatitis. Of course, the patient is going to be in chronic pain. They're going to have poor absorption of food. That's going to lead to weight loss. And they can have an onset of diabetes because, as we know, our pancreas is really the driving force in whether or not somebody has type 1 or type 2 diabetes. And if we're damaging those functional cells of the pancreatic tissue, the islets of Langerhans, we are going to make our patient more susceptible for having diabetes because they can't process insulin and glucose like a healthy pancreas would. Risk factors for chronic pancreatitis: men are more likely to have it than women. They usually will start to see symptoms of chronic pancreatitis by their 30s or 40s. Again, this is somebody who has had episodes of pancreatitis before. This is not something that just pops up overnight out of nowhere. Anyone who has a history of cholelithiasis, if they've had any type of pancreatic cancer before, trauma to the epigastric region, cystic fibrosis, other types of autoimmune diseases like systemic lupus, hypercalcemia, where we have too much calcium in the body, so we get these calcium deposits in other organs where we shouldn't have them. Those calcium deposits cause blockages, so on and so forth. Clinically, a patient's going to have chronic epigastric, right upper quadrant pain, back pain. It's going to be aggravated by fatty foods and alcohol. So these patients really need to be aware of their lifestyle. On ultrasound, the pancreas is going to start to become smaller. It's going to be more heterogeneous, more hyperechoic. We can see a dilated pancreatic duct. Of course, any prolonged process, we're going to see calcifications. We could see a portal splenic vein thrombosis. We could see extrahepatic biliary dilatation. So really a whole lot of things going on when we have this prolonged period of pancreatitis. So here we have two pretty similar appearances of chronic pancreatitis. We can see calcifications in both of them. We can see that the pancreas kind of looks small in both scenarios, looks a little bit more hyperechoic. In the picture on the right-hand side, we can even see that dilation of the duct right here. So pretty common. And it also kind of looks similar to some of the variations of cystic fibrosis. Next, we have an abscess. So this is actually the most life-threatening complication of pancreatitis, whether it be acute or chronic. An abscess in the pancreas is usually going to arise from an area of poor vascularity. So as we know, pancreatitis, it starts to kill off that normal functional tissue, right? So if that normal functional tissue is not getting the appropriate supply that it needs, it's not functioning the way that it should, it's going to start to die off. And that starts with not receiving vascularity to that region of tissue. So when we have this tissue that's not functioning, it's not getting vascular supply, right? An abscess says, oh, you're really weak, right? All of those infectious cells that's causing the pancreatitis, they see this region where nothing's really protecting it, right? There's no vascularity protecting it. There's no healthy functional cells protecting it. So it says, oh, you're super weak. Like, that's very easy for me to make my home in there. It's kind of like a squatter, right? If you're not home to protect your house, a squatter can come into your house and say, okay, I live here now. I'm taking over. I'm going to ruin this place. So, this is why we get these abscess formations, because it's a weakened area. It's going to result in a collection of infected pus. Patient's going to have fever, chills, leukocytosis. Their blood pressure can drop, hypotension, tender abdomen. On ultrasound, this abscess is going to appear hypoechoic. It could be smooth, but it's usually going to have irregular walls. And we are going to see some echogenicities within that fluid, right? Because we know it's not simple, normal fluid. It's infected pus. So it's really going to start to look kind of nasty on ultrasound. So here we have the same abscess. So this is something that you're probably looking at going, I don't even know how that's an abscess, right? Because we are used to seeing fluid as anechoic. But again, remember, this is infected pus. This isn't normal, clear-cut fluid. So this whole region, this whole irregular region is the abscess collection. And here is our little struggling pancreas. And we can see FNA here. This is where we're saying we want to be taking our aspiration of this fluid. We want to aspirate all of that fluid, get it out so we can treat this patient with antibiotics. Next, we have a pseudocyst. So this is going to be when we have a fluid collection that arises as a result of an inflammatory process, necrosis, or hemorrhage. So we can see a pseudocyst in cases of pancreatitis, but we also want to be aware that we can see a pseudocyst because of other things as well. So if we have trauma to that region, we have cystic fibrosis where we have necrosis of the tissue, we can get a pseudocyst. So we want to be aware that yes, pancreatitis and hemorrhage and tissue death are all very closely related to each other, and those are all going to be a cause of a pseudocyst, but we can kind of just have a pseudocyst for other unknown reasons as well. So clinically, the patient will have abdominal pain or any type of symptom associated with the cause of why we have this pseudocyst. They're going to have nausea, vomiting, or they could be asymptomatic. On ultrasound, we're usually going to see these typically at the pancreatic tail, so going to be really hard for us to find. They can be super variable, meaning they could be complex, they could be anechoic. They really can kind of have their own type of sonographic appearance. They're usually going to be anechoic with enhancement, but again, they're going to be variable. We could see some debris within them. We could see some loculations within them. And unfortunately, they're really prone to rupturing because we are going to see them in cases that are associated with abscess or, potential peritonitis, right? So these are not considered a malignancy in their own right, but they are associated with other more serious complications. So we need to be aware of what is going on with that patient as a whole. So here we have 3 different examples. These are all located in the tail. This last picture is not really showing any pancreatic tissue that well, but this is still located within the tail. Splenic vein right here. So you can see this is a pretty large cyst, and you're probably thinking, oh, well, it looks pretty simple, but then look at this right here, little solid component making it complex. This picture right here, again, in the tail, really large and very complex. You're like, oof, that looks like an alien, right? Kind of looks like seaweed in there. So that's going to be that solid component to that complex pseudocyst. And then right here, so again, another one of those examples where we don't want to just assume that something is an acquired cyst, right? We want to be aware of what's going on with the rest of the patient. And if we look at this pancreas looks normal, right? We probably wouldn't question any type of pancreatitis or necrosis or hemorrhage. So we want to know what else is going on with this patient. Why is there a cyst in that pancreatic tail? What did the patient's laboratory values look like, right? What am I working with? So we need to figure out why we are seeing the things that we are seeing in or around the pancreas. Now we're getting into more of kind of tumor-based finding. So our first one is going to be a cystadenoma, and I will warn you, we don't have too many pathologies left in this PowerPoint, but the rest of these pathologies all sound very similar to each other, and they all have different names. So this is really where your pathology chart is going to come in handy. So cystadenoma is also known as microcystic or serous adenoma. So on an exam or on a quiz, you could get cystadenoma as a term, or you could get microcystic adenoma, or you could get serous adenoma, and they all mean the same thing. So this is when we have one or multiple cysts in the pancreas, rather in this finding in the pancreas. So this particular tumor itself is made up of one cyst or multiple cysts. It's going to be a rare benign finding. It's going to be very common in older women, typically in their 70s. We are also going to see elevated serum amylase, so that elevated enzyme level. On ultrasound, we're going to see an anechoic mass with enhancement. So this is a cystic finding. We can see some internal septum or septations in there. The walls, the borders are going to be thick. Sometimes they can be small, so that's going to make it harder for us to find them. And they're usually going to be located in the body or the tail. So let's take a look at what they look like. So here, both of these are going to be multicystic findings. So we don't have that one solitary cyst, but we have this tumor made up of all of these numerous tiny little microcysts. And we can kind of tell that that's in the body or the tail of the pancreas because we have some pancreatic tissue here. This looks like the portal splenic confluence. So we're kind of in that body region. Same thing right here. A bunch of tiny little microcysts and pancreatic head here. So we're definitely in the body, kind of towards the tail region there. So with this finding in particular, you want to make sure that you're not just ignoring that or calling that duodenum, right? Because as we know, there's a lot of just kind of nonsense around the pancreas, and we don't want to be ignoring something that's right next to it or right adjacent to it. Next, we have a Cystadenocarcinoma. So cystadenoma, we just said, was benign, but now we're getting more into the malignancy version of that tumor. So this can either be pre-malignant or malignant in nature. This is going to be a rare, slow-growing tumor. Again, common in older women, typically in their 50s. It actually originates at the pancreatic duct, and it starts as a cystic neoplasm. So we kind of have this cystic outpouching of that pancreatic duct that then kind of turns into this malignant cellular tumor. On ultrasound, we are going to see this finding with irregular walls. It's going to have loculations inside of it. It's going to have thick walls. It's going to be hypoechoic. So it's going to look a little bit more angry than a cystadenoma. And you're probably thinking, well, what difference is this from the pseudocyst that we just saw? Right? And we're all going back to our clinical symptoms, our patient history, our patient lab values, right? That plays a huge role in what we're finding. So these look kind of like pseudocysts when you look really quickly, but look at the borders, right? Not nice and smooth. And if we look there, we're like, oh, wait a minute, it's actually not totally anechoic. It's actually complex. It has a solid component to it. Same thing here. This is the whole tumor. So we're not just looking at this. If you were just looking at that, you would think that that was a pseudocyst, but we're not. We're looking at the entire discrete mass that has that cystic central portion. Next, we have an adenocarcinoma. So this is also known as a mucinous or colloid carcinoma. So again, 3 names that this could go by. This is going to be the most common pancreatic neoplasm. It actually produces mucin itself, and it produces a lot of mucin. So it's going to start to kind of cause some blockages and problems from that as well. This has a really poor prognosis in terms of a malignancy. Men are actually more likely to get this type of carcinoma than women are. And usually we only can diagnose this because the symptoms have progressed too far. So patients tend to be asymptomatic. It progresses slowly, so by the time that they have symptoms, it's a little bit too late. Patient's going to have weight loss, loss of appetite, nausea, vomiting, stool changes, radiating back pain, painless jaundice, onset of diabetes, and then unfortunately by the time that we can find these symptoms or these symptoms arise and we can find this finding, it has already spread metastatically. On ultrasound, we're going to see loss of that normal pancreatic parenchyma. It's going to appear hypoechoic. We could see this as a poorly defined mass or a focal mass with irregular borders. We can see the enlargement of the pancreas itself. And if the mass is located at the pancreatic head, we want to be looking for high drops of the gallbladder, compression of the IVC, and biliary dilatation. If that is the case, if we are seeing this at the pancreatic head, the patient is most likely going to be a candidate for a Whipple procedure. So not all pancreatic findings or tumors are eligible for a Whipple procedure. It's not a guaranteed type of procedure that's going to help with the patient, but usually if you can get a successful Whipple procedure of the pancreas, then you have a little bit better of a prognosis. So here, two very discrete findings, right? Hypoechoic, very discrete. Next, we have an islet cell tumor. So this can be either benign or malignant, but for the most part, they are usually going to be benign. Even if you do, they're going to be malignant. Even if you do have a benign islet cell tumor, chances are you're getting that taken out, right? We're not messing around with that. So we're getting that taken out anyway. We can either have functional or non-functional. So non-functional means that this type of tumor does not produce any symptoms. Therefore, it is usually going to be malignant. And functional is usually going to produce some type of hormonal response to that tumor that is developing. So you can have functional, benign, or malignant islet cell tumors. So you can have like 4 different combination options, right? That's a lot to remember for one organ. So they're usually going to be malignant, non-functional islet cell tumors. Now, our functional islet cell tumors, we just said they are going to produce a hormonal response to that tumor that's being produced. So we are going to actually kind of further categorize those functional islet cell tumors off of what type of hormone they produce. So we can have an insulinoma, which means that they're going to produce insulin. That's going to be the most common functional islet cell tumor. It's going to cause hypoglycemia in the patient. We can have a gastronoma that is going to cause diarrhea and peptic ulcers because it's going to be producing the digestive hormones. And then we can have a glucanoma. This is going to cause pruritus of the skin or a rash of the skin. It's going to be producing glucogen or glucose a little bit more in these patients. On ultrasound, islet cell tumors are going to be super variable depending on their characteristics, right? Like, are they benign, are they malignant, are they functional, are they non-functional? If they're functional, is it an insulinoma or a gastronoma or a glucagonoma? Like, which one actually is it? We would never be able to tell that on ultrasound. We are usually going to be finding islet cell tumors in the body or the tail. They're usually going to be small, and we can kind of see these contour changes to the tissue of the pancreas. So here, the picture on the right side, this is a little bit more obvious, right? Chances are you'd probably be able to find that, but does that not look just like, hold on, as I pull it back up here. A cystadenoma? Couldn't you very easily confuse those two for each other? So again, we are going off of all of the other information that's being provided to us. Now, if we look at the picture on the left side, look at that thing, right? How would you tell the difference between that and that? Adenocarcinoma. Really, really hard, really discrete findings. So clinically, you're not really going to be evaluating these that often, but if you do happen to come across these, you need to be aware of what the differential diagnoses could be for each finding. How can you tell the difference between the two? Now, We're really relying heavily on MRI and CT for the pancreas. These are the best imaging modalities for any type of pancreatic pathology or process, or questioning anything with the pancreas. And that's because they provide slice imaging. So although we're providing real-time imaging, they are providing concrete slice imaging. They don't really have to worry about bowel gas. They don't really have to worry about surrounding structures being misconstrued for the pancreas or the pancreatic structures. And they also use contrast enhancement. So they inject their patients with contrast to make these organs and make these structures light up like a Christmas tree. So transverse, axial, and coronal images are going to be how they take their pictures of the pancreas. They don't even look at the pancreas in sagittal, so kind of like us in a sense. Now let's see what this looks like. So here we have a contrast enhanced CT exam. So there are 2 provided slices. Now, as we know, the pancreas kind of sits like in an abstract position in the body, right? It doesn't sit perfectly transverse across our abdomen. So we, when we're looking and we're scrolling through that in a CT scan, when you're scrolling down, you're able to, so this would be our first slice and this would be our second slice. Now, our first slice, you can see that natural kind of appearance of the pancreas, right? And you're like, oh, it ends there, right? You think you see your tail here. But then as you continue to scan down and you're getting slices inferior to that, we're losing a little bit of the pancreatic head. We don't see the pancreatic head here anymore. But as we slice down, we can actually see that, oh my gosh, wait a minute, the pancreatic tail goes all the way over here to the splenic hilum. Right? So look how much further you can evaluate that anatomy. And here's the splenic hilum, or the spleen rather. And then here we have an MRI. So on MRI, the pancreas displays a feathered type of pattern, and we're able to evaluate all of those soft tissue borders and all those lobulations of that organ very well. And again, we're still doing slice imaging, so we are able to evaluate the pancreatic head here. And as we slice down, we're looking at the body. And as we slice down even further, we're looking at the tail. So not too much information, but a lot of abstract information. Please make sure you understand this stuff. The adrenal lecture does not really associate too much with the pancreatic lecture. So you can jump right into the adrenal one, but please make sure you are using your pathology charts, particularly for the pancreatic information. We had all of those findings that have like 3 or 4 different names associated with them. They all look very similar. They all behave very similar. And same thing with acute pancreatitis. We have a lot of complications that are associated with that. So make sure that you have a good understanding of that information.